Hello, everyone. I am Dr. Alicia Billington, and I am an assistant professor at ETSU in plastic and reconstructive surgery. And today I am joined by Becca Howard, who is a fourth-year medical student, and she is our Misinformation Fellow. And we are going to be talking to you about some exciting things over the next few months. She's going to be joining us to help us analyze some evidence-based medicine articles. And we're going to learn how to appropriately assess articles for their validity, and also just have question answer sessions where we can actually talk about science without getting upset and heated and all political. We're just going to look at the science here.
Yes.
For today, we are going to tackle boosters, which is a very controversial topic. And at the end, you will get to hear our viewpoints on getting boosters ourselves. So this is an article entitled Protection of BNT 162b2. This is the vaccine booster against COVID-19, and this data is in Israel. This was published September 15th, 2021 in the New England Journal of Medicine. So I'll let you talk a little bit about what this article tells us briefly. Go ahead. What does it say?
So this article, it describes the confirmed rates of infection with COVID-19 and also rates of severe illness in folks in Israel who had received their first 2 doses plus a booster compared to folks who had only received the first 2 doses.
Right.
So we're trying to see how effective that booster is in preventing infection at all and preventing severe infection that might land you in the hospital.
Which are sort of 2 very different and separately important questions.
Yes. There's a second part of this study that looked, once folks had gotten the booster, what were those rates of infection in the first few days after they'd gotten the booster? And what were those rates of infection after about 12 days? In other words, they were looking at how much time does it take for the booster to develop that efficacy? And, what timeline are you at risk or more protected once you've gotten the booster?
Sure. Great. Well, let's get into a little bit more information on that. So tell me a little bit about how the data was collected.
So the data was collected from a database that is managed by the Israeli Ministry of Health. So it was collected retrospectively. They're looking at data that's already collected. They're not watching people in real time as they get in.
And that's really important. We'll talk about this throughout these podcasts about retrospective versus prospective collection. But so this is something where they went back and looked, and so it's going to be a little bit more open to maybe some confounding variables and such.
Right. You can't control for all of those things because you weren't watching for them as they happen. You can only work with the data that you have. So the data was collected from a period of July 30th to August 31st. So from 1 month. And the date it was collected was September 2nd, I think. So just a couple days after this study period ended. It included over 1.1 million people.
That's a lot of people.
That is a big group. And so they were all at least age 60 and had been fully vaccinated prior to the study.
And so that's really important, looking at what specific age group this happened in, because other age groups might perhaps behave differently.
Right.
So we have to keep that in mind as we go.
Right.
Okay.
And let's see, what else can we say?
And so they also sort of looked at, they had certain criteria for how they defined severe illness and things like that, which are all in the paper.
Yes. So that database, it provided information on what date did they get each of their first 2 doses? What date did they get that booster dose? Had they had any PCR testing done? And what were the results of those tests? Had they had any COVID-related hospitalizations? And the severity of infection, which they had defined as a respiratory rate over 30, oxygen saturation less than 94%, and ratio of partial pressure of arterial oxygen to fraction of inspired oxygen of less than 300.
So that's fancy medical terms for, they had some criteria that helped us know that they were really sick or that they were not behaving as a lot of people normally would with the disease. They were having more symptoms of the illness.
Right.
Okay. All right. So how did they, oh, this is my favorite part. Anyone that knows me knows I love statistics. So how did they analyze the data?
All right. This was definitely something I had to look into because I'm definitely a little rusty on my biostats. So they used Poisson regression.
It's French. Poisson.
And so that was the most appropriate for this kind of data because this is count data. We are counting how many people got infections within each group, the booster group and the non-booster group.
Because you can't have like half of an infection.
Right.
So
there's no such thing as a negative infection. There's no such thing as a partial infection. You either have it or you don't. And so the data, when you have count data, it tends to be more skewed to the right. So instead of a nice normal distribution that kind of has that bell-shaped curve, it's kind of shifted off to the right. So we can't use normal linear regression models when we're looking at this data because it's not going to have a normal distribution. Right. It's just the nature of the data that we have.
So fancy way of saying they analyzed the data appropriately. They did the math right.
Yes.
That's always important to look at in the paper. So that's good.
Yes. And it also mentioned in the paper that they controlled for certain variables like age, sex, cultural demographics, or the date that their second dose was received. In other words, the distance between distance in time between when they got that second dose and when they got their booster. And that's really important because, as we mentioned, doing a retrospective study, there are things that you couldn't control as the data was being collected. So when we're looking back through it, we have to control for things to make sure there isn't some other factor. Is it more likely that males will get severe infection or something like that? And you don't want that data to influence the data that you collected without you being aware of it.
Right. So good. So they eliminated a lot of those things. So what did they see? What were the results of the study?
I was pleased to find out that the study showed that compared to fully vaccinated people who did not get a booster dose, there was a protective effect for the booster. So in fact, the rate of infection in those that had received the booster dose was 11.3 times lower than those that did not receive the booster. The rate of severe infection was 19.5 times lower. And we had talked about how they also looked at how the booster rates were in the very beginning after you got your booster compared to 12 days later. And those that had received a booster at least 12 days prior were 5.4 times less likely to have confirmed infection than those who had just gotten a booster within the last 6 days.
And that kind of goes along with what we've sort of been taught, that it takes a little bit of time for the immune system to kind of gear up and react to that. So that kind of makes sense that was the result.
Yes, the body has to get that antigen, that foreign particle, and then respond to it. It takes time to build that response to it. So we don't expect the effect to be immediate. And that was actually one of the things that they had talked about in this paper. They had analyzed day by day. Let's see, since we're doing a video, I can actually just show the graph. So there was a little bit, you can kind of see how right here, it's higher right here on day one. This is the factor reduction, right? So the higher the bar is, the more protected you are against infection, right? You see on this very first day after that you got the booster, it's kind of higher, and then it dips down, and then it goes back up. And we talked about in the paper how this data point right here, it's not due to the booster.
Probably not.
No. And we'll get into that a little bit with our next question, but we expect that it would take several days for the booster to actually become effective.
So what do you think? That's a good segue. Some of the confounding factors that are affecting this study might be, and let's start with the last, statement you made about that first day. What could be affecting more protection the second it goes in you? How is that possible?
Most likely, it's behavior change. It could be that going to get your booster reminded you how important it is to social distance and wear your mask, and you have this I don't know, renewed commitment to keeping yourself healthy from COVID. And,
Sure.
and so you might get your booster dose and just go home.
Sure.
And you're not out in public, you're not mingling with people who could get you sick.
And you're probably not going to go in and get a COVID test to see if you have the virus the same day that you're getting the vaccine, because presumably you come in and they ask you if you have all the symptoms. So if you said yes, that might be a hard stop anyway. So that's probably also playing into it as well.
Right. And those were the two things that the authors had mentioned, is definitely behavior change and change in rates of testing.
Very good.
So one of the things that is usually included in these papers with data is confidence intervals. And when I described the results, I did not talk about the confidence intervals, but it's really important to do that. So why don't we talk about what confidence intervals are and why the heck we should care about them in our paper?
Sure. So confidence intervals tell us how sure can we be of the data that we're seeing. And if you see a confidence interval that's really spread out, it says we're not that confident. And the confidence interval is also somewhat based off of a p-value, which everyone kind of has heard about. And we define what we're comfortable saying is due to random chance. So most of the time we associate a p-value with 0.05. So we're basically saying 1 in 20 times we're okay with it being due to chance. And when you say it like that, that kind of sounds like a lot of letting chance happen.
Right.
But that's a 95% confidence interval. So when we look at the data, we want to see how far apart that confidence interval is. And there are times when we're going to go, that interval is very narrow, but it's shifted and it is 0. How confident are we?
We're not confident.
We're not confident at all.
No. If it has a effect of 0, that means it doesn't protect you any better
than guessing.
Then yeah.
So on the paper that you looked at here, the confidence intervals were for the confirmed infection. You said 11.3, and that confidence interval was from 10.4 to 12.3. So that's actually pretty good.
Pretty good. Would you call that pretty narrow?
I would say that's pretty narrow. I would say it's definitely, pushed far enough in one direction that we can say there's definitely something going on.
Right.
And then your other confidence interval for severe illness was 19.5, and that was between 12.5 and 29.5. So that was a little bit wider. Yeah. But I would also say that when you look at the definition of severe illness versus the definition of confirmed infection, one is kind of a yes, no based on a test. And the other one is a yes, no based on a spectrum.
Right.
And as we discussed, part of this paper, the interesting part of it is asking, well, what does a positive test even mean? Do we care about it? Well, we care about it if you're asymptomatic and you're spreading it, but we didn't even get into that here. So I think that those numbers have to be kept in mind in regards to what we're analyzing. The other thing is this is a ratio. So we're comparing, numerators and denominators to other numerators and denominators, and the math can kind of get confusing when we do that sort of stuff. So,
all right. Now, I'm wondering, I'm sure other people are curious too. Maybe some people are not as hip with Poisson regression as Alicia is, and as I newly am, I'm new expert. But, why is it important that researchers describe what kind of approach they took to analyze the data? Maybe, I know that people are reading over these articles sometimes to reproduce the information, and that's important. If the data is reproducible, it's more valid, it's more likely to be correct. So some people look at these things, they look at the research protocol and they replicate it to see if they can get the same thing. But for the average medical student who is just reading a paper for her own knowledge, or for the average community member who won't be conducting research of their own, why do we care that researchers tell us about what kind of statistical analysis they use?
Yeah, it's funny, when I used to lead a journal club in residency, it seemed like the methods section was the one part of the paper that no one read but me until I started pimping them ever. And pimping is a medical term for meaning asking a lot of questions for the non-medical people out there. I figure I better throw that in.
Yeah.
So what that means is people would see all this number stuff, skip over and go to the results because that's kind of where the meat is. Well, what happened? But the problem is if you don't analyze things appropriately, your conclusions are going to be total garbage. So in statistics, we have a saying, garbage in, garbage out. So what you want to do is you want to look at the shape, the distribution of your data and figure, is it what we say is a bell-shaped curve? Is it a Gaussian normal distribution, or is it a different type of distribution where we have to do different analytical techniques with it? I think it's important to just get used to like the generic kind of, is it normal or not normal, and go from there. And each time you read a paper, try to just get an understanding of that. And this is hard stuff. I mean, there's times when I read papers and I don't know what they're talking about and I have to go look it up. I think that's good. I think if you're reading a paper, you should try to at least get an overall gestalt of what the data looks like. The reason it's so important is because if you analyze it with the wrong test, your results don't mean anything. And so it's important as scientists that we're able to talk about the type of data and how we analyzed it so that we can make sure, oh, okay, we're all on the same page. This is a logical assessment of this. Otherwise, the results section doesn't mean anything at all. And what was interesting with this paper, and I appreciate, is they actually do have access to the data. So other people can download this data and manipulate it themselves at home in their free time. I did open it.
Of course.
You're like, who's that one weirdo that did that?
I didn't.
That's okay. They had to have like one person click on it. So dear authors, you are welcome. It was me. But I think that that's important because it allows us to all come from a same place of familiarity with how to discuss the data.
So we were talking about kind of what limitations this paper has in trying to extrapolate what we see from Israel to a broader scale.
Mm-hmm.
What do we make of this living in the US? What do we make of this on the global level as far as how effective these boosters are and whether or not we should get one?
So I think there's a couple of things, and you mentioned some of the issues with bias earlier when we were discussing it. So in Israel, they had a much higher percentage of the population that was getting vaccinated very early on. So that means a couple of things. One, they're going to have people that are much further away from getting their second dose than in the United States, because we have certainly trailed behind in that. So I think that's very different. The other consideration, we talked about this as well, is this only looks at those over 60 years old.
Right.
And presumably the makeup ethnically of that population in Israel is going to be very different than the United States. And so those are things that we need to evaluate within the United States to see how it changes between different racial groups, different ages. There's a lot of questions we still have about how boosters are going to affect the population in the United States.
Right. A couple other things that I was thinking about as I was reading through it is that, this study time frame is pretty narrow. Mm-hmm. It's just a month. And the more data we get, the more we will learn. Another limitation with the database that the information came from, it did not have information on any comorbidities of mm-hmm. any of these folks. And some of those comorbidities may affect behaviors or the choice whether or not to get a booster. You could have had more folks in one group that had lung disease or heart disease that wanted to protect themselves with a booster, and that could affect our numbers too. So again, how do you compare those numbers when we don't know them? And how do I compare a 70-year-old with COPD to a 28-year-old with really no health problems?
There's a lot of differences between looking at this one very select group of people versus an entirely different country. But I think this is great that they're doing this research, and it's unfortunate that the United States isn't doing research like this. Part of it, I think, is the way that their healthcare system is set up. It's set up such that they have a national repository of data. And in the United States, it's very disjointed, where data is coming from, many different states, and they don't always collect things in exactly the same way. So I think there's a lot of obstacles. We've definitely been working through many of those, but yeah, it's making it hard to compare apples to apples for sure.
Definitely. So we're encouraged by the data, but we kind of take it with a grain of salt, and we'll kind of see where it goes. But after reading this and going through our discussion, our big question is how do we let this influence our decisions?
That's
Like,
right.
how are we going to get the booster?
Yeah. So we have to make a decision right now based on the information that we have,
Right.
or maybe a couple of weeks ago. So based on the information we have right now, Becca, what do you think about for you? What are you going to get the booster?
I did get the booster.
I
Already got the booster about 2 weeks ago. I was encouraged by the numbers in this study, but some of it, some of my logic just kind of came from my personal life and the situation that I'm in. So I'm a medical student. I'm going through different rotations. I'm about to start a rotation in the ICU on Monday, and there are going to be a lot of really sick patients in there. And I would not want to bring something into them when they're already so vulnerable. At the same time, there's probably going to be lots of COVID patients that I'm working with, and I want to protect myself from them too. And, we have the holidays coming up. I'm going to see my grandparents, which I haven't seen some of them in a long time, some of them since before COVID started. And they are very worried about COVID. And I want to do what I can to reassure them when we're all together that I've done my part to keep myself healthy so I can keep them healthy.
So that sounds like a totally reasonable justification for getting the booster.
Yeah. So what about you? Because I know your opinions are a little different.
Well, so I'm excited about this data. I think it's great that we're seeing that there was a significant reduction in severe disease. I'm glad they didn't look at just testing positive, because if you test positive but nobody gets sick, well, what difference does that make? So I think that that's great data, and I'm excited that we're doing more studies, and there are some studies in the United States looking at Pfizer specifically. The N values are really small right now. I suspect what we're going to see is that the booster does help. The question is, how long does it help for? And my other important question is, what are the side effects associated with it? And we don't have all of the answers to these things yet. So these are going to come with time. And I'm very hopeful that we see, and I very much so suspect we will see, that the side effects are going to be similar to the second dose that was administered. And that's what we're seeing in the small values that we have already. I am going to hold off until I can see all of that data, because what I like to do when my patients come in is say, here's all the data I have to support it. Here are the reasons why. And right now I have a lot of questions that I don't have answers to for them. The other reason, and a lot of this goes to personal things, my husband just had COVID. And so we lived together, and I didn't get sick. And I actually tested negative. So what that tells me is that my second dose was actually very highly effective.
Right.
And that can be very important discussion that I have with my patients when they come in that are vaccine hesitant. I can say, look how much my vaccine protected me. I didn't get sick. And so I think that that's really important to talk with patients about, because a lot of patients are coming in right now and they're saying, well, what about all the people that get the vaccine that get COVID? And I can say that I'm personally one of the people that was in a position where my husband had it and I didn't get sick, and I feel really well protected. And the data does support that if you have the 2 doses, you're going to be pretty well protected. Now, I will say I'm not a 60-year-old from Israel. Okay.
Right.
So if I was in the 60-year-old age group, I probably would go ahead and get the vaccine right now. And so I think that the booster, it's not a black and white. I think there needs to be discussion with your healthcare provider.
Right.
And I think you need to look at your personal risk. So I think that those things are all important. What I think we can both agree on, though, is that I'm really glad we both got the first and the second shot.
Absolutely. Absolutely. If you're on the fence about the vaccine, the data is out there. Those first 2 doses really do the job.
We have lots of data on how effective they are. We have lots of data on the side effects associated with them. So I think that's something that we absolutely are huge proponents of, and we would love for everyone to get vaccinated. As far as the boosters go, I have a feeling we're going to be learning a lot more about boosters. Maybe they'll even come out with a different type of boosters. There's questions about, should you switch from Moderna to Pfizer?
Right.
The adenovector viruses, they're looking at second, shots with that. So there's a lot more to come. So I'm going to say, for right now, as far as the boosters go, I don't know, because I need more
You need
information.
more data.
But I have a feeling that data is going to be coming very shortly, and it's going to be very
Yes.
positive.
Yes, fair enough. Well, there you have it. We have two medical professionals who looked over the same data pretty objectively. We were able to have an open conversation about it. We have the same takeaways, but different approaches, different action points,
That's right.
after discussing it. And sometimes that's how medicine works. Medicine is not black and white. It's great to be able to have those
It is very great to
open
be able to have these
conversations, and yet your behavior, your choices are up to you. That's the great part about having autonomy, right?
But we do want everyone to go and get that vaccine if you can, because it's just we've seen so many people in the hospital that have been sick from it.
Yes.
And we've seen the really detrimental effects. So
Right.
cool.
Well, thanks for chatting with me.
Thanks.
This was really fun.
Well, we'll see you guys again next time on medical advocacy, and we'll be talking about
We're going to be talking about something having to do with breast cancer, breast health. October is Breast Cancer Awareness
That's right.
Month. And so we want to do something in that vein, bring some light to some issues, and we will talk through a good paper kind of in the same format. I know I'm going to learn a lot.
I always learn a lot.
Yeah. So stay tuned for our next episode.
Thanks so much. Have a great day.